uterine bleeding. Menstrual irregularities and abnormal heavy menstruation account for up to 25 to 33% of the women attending gynec OPD. Although women of any age group can be affected with AUB, it is more commonly experienced by women of 35 to 45 years, more commonly among young girls soon after attaining the menarche. The Palmer-Cohen classification is used to define the cause of AUB. It can be divided into acute AUB, chronic AUB, depending on the duration. Chronic AUB is defined as the bleeding that is abnormal in volume, regularity, and or timing for the past 6 months. It usually does not require immediate intervention. Acute AUB is an episode of heavy menstrual bleeding of sufficient quantity to require immediate intervention to prevent further loss. It can be seen in existing chronic AUB. Etiology of menorrhagia. General causes include blood dyscrasias, coagulopathy, thyroid dysfunction, genital TB. Pelvic causes include PID, adhesions, uterine fibroid, endometrial hyperplasia, adenomyosis, feminizing tumor of the ovary, endometriosis, pelvic congestion, varicose veins in the pelvis. Contraceptive use include IUD, post-tubal sterilization, progesterone-only pills, hormonal or AUB. It can be ovulatory or anovulatory. Ovulatory is irregular ripening or irregular shedding. Anovulatory, resting endometrium 80% or metropathia hemorrhagica. Palmer-Cohen stands for polyp, adenomyosis, leiomyoma, malignancy and hyperplasia. Cohen, coagulopathy, ovulatory dysfunction, endometrial, iatrogenic, not yet classified. Leiomyoma can be classified based on the location into submucosal or other. Investigations. AUB patient should be completely investigated. Complete hemogram, bleeding time, clotting time, thyroid profile, pelvic sonography, diagnostic hysteroscopy, endometrial tissue sampling by DNC or endometrial aspiration, diagnostic laparoscopy. Sonosalpingography can delineate a submucous fibroid clearly. Pelvic angiography is required when the cause of menorrhagica is not detected by other means. This shows varicosity and arteriovenous fistula. Management. General measures to improve the health status of the patient. Advice regarding proper diet, adequate rest during menses, oral administration of hematinics, vitamins, and protein supplements, and to maintain a menstrual calendar, noting the duration and extent of blood loss. Treat the cause. Menorrhagia in young women, contraception not desirable. If conception is desired, then use ethamsalate, NSAID, tranexamic acid for 3 to 4 months. If contraception also is desired, but pregnancy not desired, use combined OC pills, progestins, Mirena, gonadotropin releasing hormones for 3 months. If it is effective, continue 6 to 9 months and required and follow up. If the management fails, minimally invasive surgery and hysterectomy with conservation of ovaries is preferred. In older women, rule out cancer and uterine pathology. If there is normal uterus, then medical therapy with combined OC pills are contraindicated over 40 years. Progestin and others. If no response, then hysterectomy with the removal of ovaries after 50 years is done. Uterine pathology, if present, surgery is the preferred mode. In ovulatory cycles, oral non-steroidal anti-inflammatory drugs such as mefenamic acid 500 mg TID along with antacids. Other drugs in this category are naproxen, ibuprofen. Blood loss is reduced by 30 to 40%. These drugs are effective in ovulatory bleeding. And in IUCD users, they are anti-prostaglandin and inhibit cyclooxygenase COX activity. They decrease the menstrual bleeding but have no effect on the duration of menstrual bleeding. Tranexamic acid is the currently most commonly prescribed drug for control of excessive menstrual bleeding, given 500 to 1000 mg 2 or 3 times a day during heavy menses. The blood loss is reduced by 35%. Cyclical OC pills, progestogens in endometrial hyperplasia, Mirena IUCD. Minimally invasive surgery includes endometrial thermal ablation, endometrial resection, and others. Hysterectomy in selected cases. Gonadotropin releasing hormone analogs. They are not effective in immediate control of bleeding. However, their use can induce amenorrhea. In women manifesting obvious pathology, corrective measures for the same are called for, depending upon age and a desire for retaining menstrual and childbearing periods. Removal of an IUCD if medical therapy fails. Myomectomy or hysterectomy for uterine fibroid. Adenomyomectomy or hysterectomy for adenomyosis of uterus. Laparoscopic lysis of adhesions for chronic PID. Electrocautery or laser vaporization of endometriosis. And drainage of chocolate cyst in pelvic endometriosis. Hysterectomy with or without the removal of adnexa according to the age and the individual. If the patient is suffering from bleeding disorder, hematologist opinion should be sought. Uterine artery embolization in varicose vessels, von Willebrand disease, intravenous desmopressin is preferred. 80% of AUB occur in anovulatory cycle, 20% occur in ovulatory cycles. Palmacoin classification. Polyp. It is categorized and defined by ultrasound, saline sonography, hysteroscopy with or without histopathology. Adenomyosis. It is diagnosed by ultrasound and MRI. MRI is expensive and not available in many centers. Many cases of adenomyosis are asymptomatic and only diagnosed on hysterectomy specimen. Leiomyoma. Many leiomyomas are coincidental finding and are not the cause of AUB. Because of the number, different location and size, this group is divided into primary, secondary and tertiary group. Primary classification reflects only the presence or absence of leiomyoma as determined by ultrasound. In secondary classification, it is necessary to distinguish that myoma involve the uterine cavity, as these are the ones that are likely to cause the AUB. The ones away from the endometrium are unlikely to do so. Tertiary classification involves the submucosal growth. It includes number, size, location of the myoma. Malignancy and pre-malignant lesion, AUB-M. This group is rare in reproductive age group but may occur in women with PCOD and chronic anovulation. The diagnosis is made by histopathological examination of the endometrium or by hysteroscopic biopsy. Coagulopathy, AUB-C. It consists of a spectrum of systemic disorders of hemostasis that can cause AUB in around 13 to 20% of women of reproductive age. The most common is von Willebrand disease. However, many of these may be asymptomatic and not related to AU. Ovulatory disorders. About 80% are anovulatory cycles with unpredictable, irregular menstrual cycles, some with heavy bleeding. About 20% are ovulatory but may be a consequence of luteal out of phase loop events with deficient progesterone. Some of these are caused by hypothyroidism or hyperprolactinemia. AUB-E. The mechanism regulating the local endometrial hemostasis secondary to abnormal secretion of prostaglandins is as explained earlier. In rare cases, it is due to tubercular endometritis or infection, particularly chlamydal infection. Iatrogenic. It is caused by steroid hormones administered as contraceptive, especially in low dose. IUCD copper T may cause unscheduled breakthrough bleeding or menorrhagia. Non-classified. Rare causes not well defined, diagnosed are otherwise arteriovenous malformation, varicose vein of the uterine vessels, or myohyperplasia. Metropathia hemorrhagica. It is specialized form of an ovulatory AUB seen in women between 40 to 45 years of age. It is not related to parity. The symptoms are typical. The woman develops continuous painless vaginal bleeding, sometimes starting at the onset of menses or preceded by 6 to 8 weeks of amenorrhea.